Right, so in this first part of the cardiovascular lecture series, we will look at anatomy of the heart in particular. These are the things we are going to cover in this part of anatomy of the heart. We look at the anatomical position of the heart. We'll also look at the arterial and venous drainage of the heart. We'll describe the layers of the pericardium and state the role of each. We'll describe the chambers and valves of the heart. We'll talk about the histological layers of the heart wall. We'll look at the histological features of cardiac muscle cells. And lastly, we look at the components of the cardiac conduction tissue. Let's begin with the first one, focusing on the anatomical position of the heart. So this is the heart. Commonly, if somebody asks you to say where the heart is found, then the first thing that comes to your mind is to say the heart is on the left. I don't like that so much because not fully accurate. It's not even passing the message that I really wanted to get. The heart is located within the middle mediastinum. You may know that the mediastinum is a region within the thoracic cavity between the right and the left lung. So this is the mediastinum. And mediastinum is divided into two, maybe from around that line there. The region above that line is called the superior mediastinum. And the region below that is called the inferior mediastinum. The inferior mediastinum is further divided into three, from anterior to posterior, based on the location of the heart. So the structures in front of the heart are in the anterior mediastinum, and the structures behind the heart are in the posterior mediastinum. Then the structures around the level of the heart and the heart itself is within the middle mediastinum. Having said so, the heart is actually a midline organ. If somebody was to shoot you direct in the middle of your thorax, most likely the bullet will get the heart. So it's a midline organ. Don't say it's on the left. But why do we say usually it's on the left side? The storyline is this. Look at that radiograph, which shows you the outline of the cardiac silhouette. So we are seeing this is the cardiac shadow, basically. This is the midline of the body. We see that, yes, the heart is a midline organ, but 1/3 of the heart falls to the right of the midline, and 2/3 of the heart fall to the left of the midline. So the concept here is that there's a bigger proportion of the heart that falls to the left of the midline compared to what falls to the right of the midline. Otherwise, the midline organ, but yes, a bigger part of it is to the left and a smaller part of it to the right. I hope you understand that. So it's located in the middle mediastinum with 2/3 of it to the left of the midline and 1/3 to the right of the midline. In terms of its position, I want to say a number of things. One of those things is to just talk about the apex of the heart. The apex of the heart lies anterior, inferior, and to the left. And it's a prominence of the left ventricle. So the cardiac apex is a projection from the left ventricle. If the apex is anterior, then the base of the heart is posterior. Don't be tempted to say that the base of the heart is below. It is not inferior, but it's posterior. And the base of the heart is formed predominantly by the left atrium. Again, remember I said atrium. I didn't say auricle. So the base of the heart is posterior and is formed by the left atrium. Let's talk about the borders of the heart. I want to talk about some 3 cardiac borders. The left cardiac border, the right cardiac border, and the inferior cardiac border. Let's start with the right cardiac border. This radiograph helps us to figure out the cardiac borders well, and we'll be using this and projecting it on this one. Or let's use this and then translate it there. So the right cardiac border is this one, formed predominantly by the right atrium. The right atrium forms the right cardiac border. If you extend that superiorly, you find the superior vena cava there. And maybe if you stretch it down, you find the inferior vena cava there. So on this one, this is the right cardiac border, which is formed by the right atrium. The inferior vena cava is there. And this is superior vena cava. So that is the right cardiac border. How about the left cardiac border? We see it being formed by the left ventricle predominantly here. And if you extend that up, you find the left auricle. I'm using the term auricle, not atrium. And then if you extend that up above, you'll find the pulmonary arterial system there. And if you extend that up, you'll find the arc of the aorta there, what we call the aortic knuckle. So if you translate that on this radiograph, that is the aortic knuckle corresponding with that one. Then here, that's the pulmonary bay corresponding with the pulmonary arterial system there. Then from there to there is the left auricle corresponding with that one. And the rest of it is the left ventricular border. So the left cardiac border is formed by the left ventricle and left auricle there. But of course, above it, we have the pulmonary bay and the aortic knuckle. How about the inferior border? We may not be able to see inferior border here nicely because it merges radiologically with the liver and the diaphragm. But on this one, you can see the inferior border is predominantly formed by the right ventricle, predominantly right ventricle. And a small part by the left ventricle. So those are the borders of the heart. Right. So I want you to get then at this point that the heart is not just a 2D thing with right, left, and they are just on the same coronal plane, not quite. The heart is slightly rotated so that the right ventricle is in front, as you can see, and the left atrium is behind. That's why we can't see it here. Of course, in drawings, we may show them all in one plane for the ease of understanding. But in the real sense, the right ventricle is anterior, the left atrium is posterior, the right atrium is to the right, and the left ventricle is to the left. The heart is rotated. Let's talk about the arterial blood supply to the heart then. So the heart receives coronary arteries, the right and the left coronary artery. They all arise from the ascending aorta. The ascending aorta is the part of the aorta going up from the heart. These vessels largely run between the pericardium and the myocardium. That's what we call the subepicardial zone. Maybe in these images, we see the vessels there, right coronary, left coronary. The vessels run in the subepicardial zone. Now, left coronary arteries here, usually it's a smaller artery compared to the, sorry, this is the right coronary artery. It's a smaller artery compared to the left coronary artery, which is a bigger artery. Having said so, the left coronary artery supplies a bigger mass of the heart compared to the right coronary artery. Let me say that again. The left coronary circulation supplies a bigger mass of the heart compared to the right coronary circulation. And there are two important big branches of the left coronary system. We have that one, which we call the left circumflex, and this one, which we call the left anterior descending. It may also be called anterior interventricular. I like calling it left anterior descending. So left circumflex and left anterior descending are branches from the left circulation. This is the right coronary artery. Even though we are saying that the left coronary artery is a big artery, supplying a bigger mass of the heart, there is something called coronary dominance. Coronary dominance refers to the artery that give branches which supply most of the conduction tissue of the heart. The coronary artery that gives branches that supply most of the conduction tissues of the heart. The conduction tissues include things like sinoatrial node, AV node, and the atrioventricular bundle of His. Even though the right coronary artery is a smaller artery, usually it is the one that supplies most of the cardiac conduction tissue in many of the individuals. For that reason, in most cases, we talk of a heart having a right coronary dominance, even though the right coronary artery is a smaller artery. So don't confuse. Coronary dominance refers to the coronary artery that supplies most of the cardiac conduction tissues. In most cases, we have a right coronary dominance. In a few cases, you may have a left coronary dominance. And in even fewer cases, you may have coronary codominance, which means both arteries supply the conduction tissues almost equally. That has some clinical implication in terms of if the right coronary artery was to be blocked vis-a-vis if the left coronary artery was to be blocked in heart attack. Even though the right coronary artery is a smaller artery, if it's blocked, the patient is likely to present with disorders of rhythm compared to if the left coronary artery was to be blocked, based on what we just said. Okay, so that would be the right coronary circulation as the left coronary circulation with its two branches, left circumflex and left anterior descending. How about the veins that drain the heart? Principally, the veins that drain the heart are called cardiac veins. Some of them follow the artery, some of them run separately. There are many veins, we don't have to mention their names. Remember, they carry deoxygenated blood from the myocardium back to the heart. So the aim here is therefore to take blood to the right atrium. You know, the heart pumps blood, but it also needs oxygen. So the coronary arteries supplied the myocardium with oxygen. Cardiac veins carry the oxygenated blood from the myocardium back to the heart. Those cardiac veins usually converge, most of them converge to form a large vein, which we call the coronary sinus, which drain into the right atrium. So that shows you still the cardiac veins merging to the coronary sinus. Even that shows you cardiac veins merging to the coronary sinus. Usually the coronary sinus is behind and inferior relatively. If this is the left atrium behind, this is the right atrium. This is the inferior surface of the heart now, the diaphragmatic surface. That is where the coronary sinus is. And take note, it empties into the right atrium, just like the superior vena cava and the inferior vena cava as well, carrying the oxygenated blood. Now we can talk about the pericardium. I want you to imagine that this is the muscle layer of the heart, which we call myocardium. The pericardium refers to the membranes that surround the heart. There are tissue layers that surround the heart. There are two parts of pericardium. This gray one, I hope it's gray, is called the fibrous pericardium. Fibrous pericardium is a connective tissue layer that surround and protect the heart. So this is fibrous connective tissue. That is why we call it fibrous pericardium. The main aim is to protect the heart. That is one of the layers of the pericardium. The second layer of the pericardium is this one outlined in green. What do you notice? You notice that this layer outlined in green surround, or rather line, the inner surface of the fibrous pericardium, and then it reflects to surround or to line the outer surface of the myocardium. This green layer is known as the serous pericardium. Histologically, serous pericardium is a simple squamous epithelial lining. This is what we called some time back mesothelial layer. Simple squamous epithelial lining. It's the one that secretes some fluid into the pericardial cavity. Remember, it's epithelial. It's now not connective tissue. It is mesothelium. As we can see here, the serous pericardium has two parts. The part that is lining the inner surface of fibrous pericardium is called the palatal layer of the serous pericardium. And the part that lines the outer surface of the myocardium is called the visceral layer of the serous pericardium. So we can say that the serous pericardium has two parts: the visceral pericardium, the palatal pericardium. Those are parts of the serous pericardium. Now, some people then want to argue and say that pericardium has three layers: fibrous pericardium, palatal pericardium, and visceral pericardium, and you can still understand what that means. If you argue that there are two layers, then it's okay: fibrous pericardium and serous pericardium. But remember, serous layer has two parts. The gap between the palatal and the visceral layer is what we call the pericardial cavity, and that is where the pericardial fluid is located. Remember, the pericardial fluid will lubricate the heart so that it prevents friction during the motions of the heart. So those are the layers of the pericardium. Now, so that we don't confuse with something else, let me take this opportunity to also tell you about the wall of the heart. So the heart is described to have three walls, three layers on the wall. The outermost layer is called epicardium, and the one I'm pointing at is epicardium. Now follow that round, and you'll notice that epicardium is actually the visceral layer of the serous pericardium. They mean the same thing. So that visceral pericardium is actually part of the heart wall. It is the outermost layer of the heart wall. Then that other color that I'm unable to pronounce is the myocardial layer, the layer that contains cardiac muscle. There's another layer inside. Now the one I've introduced, the blue one. That one is called the endocardial layer. The endocardium is the innermost layer of the heart wall. And as you can see, the endocardium is the one that actually forms the valves. That is why if you have infections of the valves, then you'll talk about infective endocarditis. This gap between the epicardium and the myocardium is called the subepicardial zone. And that is where the blood vessels run predominantly. They are subepicardial. Remember, this is the cavity representing the chambers of the heart. So I just introduced this here so that you distinguish it from pericardium, but also understand that the visceral layer of the serous pericardium is actually the epicardium. Also to notice therefore that fibrous pericardium and parato pericardium are not part of the definitive heart wall, but visceral layer of the serous pericardium is part of the definitive heart wall. Now we can talk about the chambers and valves of the heart. We can use this image to orient us through how blood flows through the right heart chambers before we talk about the right heart chambers themselves. Let's consider that these are veins going back to the heart. So usually from the upper part on the right side, we have the right brachiocephalic vein. And from the upper body on the left side, we have the left brachiocephalic vein. These two join to form the superior vena cava, which empty its blood into the right atrium. Remember that the right atrium also receives blood from the inferior vena cava. Generally, the blood entering by the superior vena cava comes from the upper part of the body. The blood entering the right atrium from the inferior vena cava comes from the lower part of the body. And the junction between upper and body in upper and lower part of the body in this case is the thoracic diaphragm. So the region above the diaphragm enter via SVC, and the region below the diaphragm drain via the IVC. Of course, there are two exceptions there, the heart and the lungs. For the heart, remember, it will drain via the coronary sinus, again into the right atrium. For the lungs, remember, blood from the lungs enter via the pulmonary veins, which enter the left atrium and not the right. Well, if you remember that there were some bronchial veins as well, maybe those ones will now enter through the superior vena cava. Okay, so blood from the right atrium moved to the right ventricle via the tricuspid valve, and blood from the right ventricle will move to this vessel here via the pulmonary valve. I know you want to call that one the pulmonary artery. I prefer calling it the main pulmonary artery rather than calling pulmonary artery. And this is the reason. We know that each lung has an artery, which is called pulmonary artery, which means there are two pulmonary arteries. But there's only one vessel that comes from the right ventricle. So to be clear in our terminology, the vessel that comes from the right ventricle is called the main pulmonary artery. or you can call it pulmonary trunk. Then that vessel is the one that now divides into two, the right and the left pulmonary arteries. The blood in the pulmonary arteries is headed to the lungs. Remember, this is carrying deoxygenated blood, and eventually that blood therefore is redirected to the lungs for gas exchange. Having talked about the right heart chambers, let's now, having talked about the right heart, how blood flows through the right heart, we can now talk about the right heart chambers. And we can start with the right atrium. So the inside of the right atrium has two surfaces, a smooth one like that, and a rough one like this. The smooth part of the right atrium is known as the sinus venarum. This rough part of the right atrium is known as musculi pectinati. Well, you can call it the pectinate muscle. The two surfaces are separated by this linear ridge. From inside, remember, that linear ridge is known as the crista terminalis, or the terminal crest. Remember, this has been cut off from here. So the crista was actually falling somewhere here. Maybe that one is still representing it. It's just been cut so that we can see it. So this is the crista up to there. The rough part is musculi pectinati, the smooth part is sinus venarum. It is this trabeculated part that extends into this part here. So you can see that is still trabeculated. And that extension is what we call the right atrial appendage, or basically the right auricle. So an auricle is an ear-like extension of the atrial chamber. An ear-like extension, ear like that one, ear-like extension of the atrial chamber is what we call an auricle. The right auricular appendage, or the right auricle, is an extension of the trabeculated part of the right atrium. The smooth part of the right atrium contains some things that I want to talk about. There's that small depression there, which we call fossa ovalis. It represents the embryonic foramen ovale. In adults, we don't have foramen ovale, or let me say postnatally, we don't have foramen ovale. Instead, we have fossa ovalis. The upper margin, the upper border of the fossa ovalis is that ridge, which we call the limbus. So that's the limbus. When you look at fetal circulation and cardiovascular changes at birth, we'll elaborate on the concept of fossa ovalis and the concept of the limbus more. Apart from that, the right atrium contains some 3 valves within it. We have the Eustachian valve. The Eustachian valve is the valve that guides the opening of the inferior vena cava. This valve is particularly important in embryonic life rather than in the postnatal life. The main aim of this valve is to redirect well-oxygenated stream of blood from the inferior vena cava to the foramen ovale in fetal life. So it redirects that blood from the inferior vena cava to the foramen ovale in fetal life. We may not have a bigger use for it postnatally, but prenatally it's very vital. The Thebetian valve is the valve that guides the opening of the coronary sinus. So that's the opening of the coronary sinus. And the tricuspid valve is the valve between the right atrium and the right ventricle. That is the tricuspid valve. There are two important sites within the right atrium that I also want to talk about. If you follow the crista terminalis up to that point and slightly below and behind it there, that will be the location of the sinoatrial node. So around there is the location of the sinoatrial node. Again, between the opening of the coronary sinus and the atrioventricular valve around this region is the location of the atrioventricular node. So the AV node is found around there and SA node is found around there. That is right atrium. Let's now talk about the right ventricle. The upper part of the right ventricle is smooth in its inner texture. That smooth part of the upper of the right ventricle is known as the infundibulum of the heart, or the infundibulum of the right ventricle. You may also call the conus arteriosus. That conus arteriosus is the one that merges, narrows like a funnel, and continue into the main pulmonary artery. Of course, there's a valve separating the two, and that valve is a pulmonary valve. We'll talk about it shortly. The lower part of the right ventricle is rough, as you can see here. The roughness is described as trabeculae. So it is trabeculated. We have two types of trabecular systems. We have two types of roughness within the ventricles. There's what we call papillary muscle. Papillary muscle are these rough muscular projections that anchor the valve. We call them papillary muscles, the ones that anchor the valve. Then we have what we call trabecular crani. Trabecular crani are these ones. We can see these ones. They don't anchor the valve, but they're still rough. Now, there are two types of trabecular crani. These longitudinal ones are called the ridges, and the tiny ones that join them are called the bridges. Like that is a bridge, then that's a ridge. These are ridges, and that tiny one is a bridge, or that one is a bridge, that's a bridge, but these other two are ridges. So we have ridges and bridges. Those are the trabecular systems within the right ventricle, although we can extrapolate that also to the left ventricle actually. One of the trabecular systems is worth mentioning. We call it the septomarginal band, or otherwise known as the moderator band, the one I'm pointing at. The moderator band extends from the interventricular septum. This is the interventricular septum, the septum separating the right ventricle from the left ventricle. So that is the interventricular septum. It extends from there up to the base of the anterior papillary muscle. We call that the moderator band or the septomarginal band. It is important to mention it because it contains the right branch of the conduction tissue of the heart. It contains the tissues that conduct impulses to the right ventricle. So it's very important to mention it. We will revisit that shortly. Okay, so those are the right heart chambers. We've talked about the trabecular systems. We've talked about the papillary muscles. And I've mentioned something about the moderator band. All right. Now let's talk about the left heart chambers. perhaps we'll do what we did first, talk about how blood flow through through the left heart chambers. That one we've already talked about. So when blood moves to the lungs, it goes for oxygenation, then come back through the pulmonary veins to the left atrium. Remember, the blood from the lungs is oxygenated. While we had two pulmonary veins, right and left, we have four. Sorry, while we had two pulmonary arteries, right and left, we have four pulmonary veins. Each lung has two pulmonary veins, the superior and the inferior pulmonary vein. So we have the left superior and left inferior pulmonary vein, right superior and right inferior pulmonary vein, emptying it independently, emptying their blood independently into the left atrium. From the left atrium, blood flows via the mitral valve to the right ventricle. From the right ventricle, blood flow through the aortic valve to the aorta. Aorta has three segments. The segment of the aorta going up is known as ascending aorta. The segment of the aorta turning is called the aortic arc. And the part of the aorta going down is called the descending aorta. Conventionally, we can still divide the descending aorta into two based on the anatomical region it's found. So we have the thoracic segment of the descending aorta, and we have the abdominal segment of the descending aorta, which means that there's a part of the aorta going through the thorax. Then when it crosses the diaphragm, it enters the abdomen. So that last one, you don't have to give it that long name, abdominal segment of the descending aorta. We can just call it abdominal aorta. But I want us to take some note about the ascending and the arc of the aorta in terms of the important branches. The ascending aorta give you the coronary arteries. We talked of the right and left coronary artery supplying the heart wall. The arc of the aorta give you three arteries. The first one, this one, is called the brachiocephalic trunk. Okay, the spelling is like that, but now it's not a vein, it's an artery. You can call it brachiocephalic artery or brachiocephalic trunk. This one takes blood to the right side of the body, on the upper right side of the body. So it gives you two branches, one that goes to the right upper limb, the right subclavian artery, and the one that goes to the right side of head and neck, the right common carotid artery. So those ones go to the right. Then this second branch from the arc is the left common carotid, and this last branch is the left subclavian artery. The point is this, that the arteries that go to the left sides arise independently from the arc of the aorta, while the one that's going to the right side has a common stem of origin before they split. So otherwise, this is the right subclavian, and it's the mirror image of that one. Maybe it's not a mirror per se, but it's synonymous to this one, left subclavian. That's the right common carotid, and this is the left common carotid. Having mentioned that, we can now just highlight something about the inner chambers of the right atrium and, left atrium and left ventricle. The left atrial chamber is predominantly smooth, as we can see, except the left auricular appendage that will be trabeculated. So the left auricular appendage is trabeculated, but the rest of the left atrial chamber is just smooth. Remember, there are 4 veins that open into the left atrium. From the left atrium, we have the mitral valve that take you to the left ventricle. The left ventricle is predominantly trabeculated, similar trabecular system types that we talked about. For the right ventricle, we can extrapolate that concept here as well. Now, look at the wall thickness of the left ventricle and compare that to the right ventricle. You notice that the left ventricular wall is thicker compared to the right ventricular wall. This one here is the interventricular septum. The septum separating the right and the left ventricle. Usually it has a thicker lower part, which is predominantly muscular. Actually, we call the muscular portion of the interventricular septum, and an upper thinner part, which is predominantly membranous. We call it the membranous portion of the interventricular septum. It separates the right and the left ventricular chambers. The thickness of the septum will be, of course, similar to the thickness of the left ventricle, because the physiology here is that, the physiology here is that the left ventricle pumps blood against higher pressure, systemic circulation. So the wall thickness is more. We still see that here, just to capture that, yes, we have papillary muscle still and trabecular cranial still. Now we can talk about the valves of the heart. There are 2 types of valves in the heart: semilunar valves and atrioventricular valves. We can begin with the semilunar valves. Semilunar valves are the valves found between the ventricles and their corresponding outflow tracts. Remember, the outflow tract from the right ventricle is the aorta. From the right ventricle is the pulmonary trunk, and the outflow tract from the left ventricle is the aorta. So the valve between the left ventricle and the aorta is called the aortic valve, which is this one. And the valve between the right ventricle and the pulmonary trunk is called pulmonary valve, which is this one. I want you to notice that the 2 arteries are related like in an anterior-posterior manner. The main pulmonary artery is in front of the aorta. So usually those 2 arteries cross. If you can look at my video in a Wakanda manner, the right ventricle, which is that one, give you artery that go to the left and crosses anterior. The left ventricle, which is from the left, gives you aorta, which goes posterior and to the right. So they cross like that. And that is why now their valves are related that way. The pulmonary valve is anterior to the aortic valve. Consider this to be the anterior part, that's posterior. This is right side, this left side. Each of the semilunar valves just made up of 3 leaflets attached directly onto the inner vascular wall. So 3 leaflets attaching directly into the inner vascular wall. That is how a semilunar valve is organized. And so when you look at the lumen, the valve itself from above, it will give you that nice Mercedes-Benz sign, as you can see there. There's some terminologies that you may also come across. The term aortic sinus. An aortic sinus refers to this pocket here, formed by a leaflet and the inner aortic wall. Those are the ones we call aortic sinuses. So that is the right aortic sinus, which gives you the right coronary artery. the left aortic sinus, which gives you the left coronary artery, and the posterior aortic sinus, which does not give you any coronary artery in a normal situation. Okay, so that would be, okay, this image shows us how the arteries cross, what I was telling you. Right ventricle gives you main pulmonary trunk, which crosses to the right. Left ventricle gives you the aorta, which crosses through the, what did I say? The right ventricle gives you the main pulmonary artery, which crosses to the left, while the left ventricle gives you the aorta, which crosses to the right. And you can see the aorta lies behind the main pulmonary trunk. This has implications on where you will hear the sounds from the different valves. The sound from the pulmonary valve, although it's coming from the right side, it will be heard somewhere on the left, around there. And the sound from the aortic valve, although the vessel is coming from the left, it will be heard somewhere to the right of the patient. Now let's talk about the atrioventricular valves. An atrioventricular valve is a valve between the atria and the ventricle. Each atrioventricular valve has three anatomical components. We have this one, which we've called papillary muscle. The strings you see here are called chorda tendini, and that membrane there is a leaflet, or you can call it the cusp. So each atrioventricular valve has those three basic components: papillary muscle, chorda tendini, and the cusps, which we can call the leaflet. Remember, the valve is largely found within the ventricle, and maybe you don't see it much from the atrial side. These structures we're talking about are on the ventricular chamber rather than on the atrial chamber side. This image captures those valves. This is an image of the heart viewed from above. This is the front, this is behind, this is to the right, this is to the left. So we see the valves which give you the Mercedes-Benz sign, pulmonary valve and aortic valve. Then this is the left atrioventricular valve, and this is the right atrioventricular valve. The right atrioventricular valve has three cusps, and that is why we call it tricuspid valve. The left atrioventricular valve has two cusps, and that is why we call it the bicuspid valve. The bicuspid valve is also called the mitral valve. You can find out the meaning of mitral, actually. Okay, so that was the chamber and valvular anatomy of the heart. Now let's talk about histological layers of the heart wall. We've already alluded to this, so we'll just pass over this quickly. That the wall of the heart has three histological layers. The innermost layer is the endocardium, which is lined by simple epithelium. Basically, the endothelium forms a barrier between the heart chambers and the heart wall. And remember, endocardium forms a barrier between the chambers of the heart and the heart wall. Endocardium is also the one that forms the valves of the heart. The middle layer is called the myocardium. Myocardium contains cardiac musculature, and usually is the thickest layer. Of course, we mentioned that the wall thickness of the left ventricle is even more than the wall thickness of the right ventricle. Epicardium is the visceral layer of the serous pericardium. Remember, I told you that the blood vessels will run in the subepicardial zone, somewhere there. External to the epicardium is the pericardial cavity, then you have the parietal pericardium and the fibrous pericardium. Okay, now let's review histological features of cardiac muscle cells. This one, you most likely have also already done. If you remember, we've talked about histological organization of muscle tissue, and cardiac muscle is one of them. In that lecture, we said, if you want to look at histological features of muscle, there are some 5 parameters that you need to check. The first one is the shape of the cells. And for cardiac muscle, the cardiac muscle cells are short. As you can see, from there to there, from there to there. And this is especially to distinguish them from skeletal muscles, which are usually elongated. The other parameter we check is the number of nuclei in the cell. For cardiac muscle, we can say that majority are mononucleated, as you can see, although a few are binucleated, as we can see in that one. Remember, for skeletal muscle, they are multinucleated, and that means maybe 100 nuclei and above. For smooth muscle, they're mononucleated. You also look at the location of the nucleus, and for cardiac muscle, the nucleus is centrally located. For skeletal muscle, they'll be peripherally located, and for smooth muscles, centrally located as well. We also check the arrangement of actin and myosin fibers. If actin and myosin fibers are regularly arranged, in light microscopy, we will see alternating dark and light bands, as you can see in that zone there, or even there. Actually, overall, you can see it everywhere. When you have those alternating dark and light bands, the dark bands represent myosin zones, and the light bands represent regions lacking myosin. If you remember the concept of the A band, the dark bands, and I band, the light bands. So that arrangement of alternating dark and light bands is what you call striation. Cardiac muscle, just like skeletal muscle, are striated. Lastly, we look at how the cells join. So here, for cardiac muscles, we see that they join end to end. And those specialized junctions between one cell and another are the ones we call the intercalated discs. Remember, intercalated discs contain 2 major components: desmosomes, which hold the cells together. So there are their junctions. And we have gap junctions, which allow free communication of ions between one cell and another. So they're communicating junctions. One last thing is that cardiac muscle cells are branched. As you can see there, that's branching, maybe that one as well, and even that one if I'm not forcing it. So these are the histological features of cardiac muscle cells. Now we can finish this part of the lecture by talking about components of cardiac conduction tissue. Cardiac conduction tissue, or otherwise called the conducting system of the heart, refer to the path followed by cardiac electrical impulses. This path consists of specialized cardiac muscle cells. So they're just muscles, by the way. It's not nerves, it's not epithelium, it's not connective tissue. And specifically, they are cardiac muscle cells. Why are we saying they're specialized? They have some unique features. One of them is that these are the ones that tend to be binucleated, actually, while the others are usually mononucleated. These are the ones that have several gap junctions within the intercalated discs. They have more gap junction than the rest. And it makes sense. They're supposed to be conducting impulses. Anyway, last but not least, these cells have fewer actin and myosin fibers compared to the rest of the cardiac muscle. The implication of that is that these muscles, therefore, will contract less compared to the rest of the cardiac musculature. Those are their special features. So let's outline the path. That image shows us that green is the outline of the path, but let's approach it in a different way. Maybe from that image, we can now trace the path of the conduction tissue. We can put that point there to refer to the sinoatrial node. Remember, it's somewhere within the right atrium, just below the opening of the spira vena cava. The sinoatrial node is a pacemaker, is the one that initiates the cardiac electrical impulses. When it initiates that, it takes impulses to the left atrium via that path which we call interatrial pathway, because it's connecting two atria, the right atrium and the left atrium. But impulses also move from the sinoatrial node to the atrioventricular node. And because these three channels connect two nodes, we call them internodal pathways. Impulses move from the sinoatrial node to the AV node via the internodal pathways. There are three internodal pathways: the anterior, middle, and posterior internodal pathway. They have some names of people, but I prefer calling them anterior, middle, and posterior so that we don't really struggle so much to remember the names of people. And especially if you're not familiar with those names, it can easily frustrate you, as it usually does to me as well. So we are here. Impulses have reached the AV node. The AV node is the only normal electrical connection between the atrial and the ventricular chambers. It's the only one. So impulses cannot move from the atria and pass through that other route or that other route. If it does, that would be abnormal. The reason is because these other regions are electrically insulated because of the presence of what we call the cardiac skeleton. The cardiac skeleton consists of fibrous connective tissue within the heart that serve three functions. They form the origin of the cardiac muscle cells. So cardiac muscle cells are attached onto that fibrous skeleton. And two, they anchor the valves. So the valves attach onto those fibrous skeleton. And three, they insulate, they provide electrical insulation so that impulses cannot move from the atria to the ventricles anyhow. Impulses can only move from the atria to the ventricles through the AV node. But why is there importance of having an AV node? Why not just a direct path? The AV node is a site of conduction delay. So when impulses reach here, they take some time. It is important that impulses take some time at the AV node. Why? Look, when we talk of impulses moving from the sinoatrial node to the AV node and also to the left atrium, it simply means that that's a depolarization sequence going on. An action potential has moved. Muscles respond to action potentials by contraction. So if impulses move from the SA node to the AV node and also to the left atrium, it simply means that the muscles of the right atrium and the muscles of the left atrium undergo depolarization. That means that they will contract then. If they contract, you want the blood that they are pumping to go to the ventricles. In that case, you don't want them, the atria and the ventricles to contract at the same time. You want a situation where when the atria contract, the ventricles are in relaxation so that it can allow for ventricular filling. Now that is why there's a delay there, so that those impulses don't move direct to the ventricles at the same time, because that would mean that the atria and the ventricles will contract at the same time. The venodal delay allows the atrial mechanical events to be ahead of the ventricular mechanical events. After the delay, of course, then impulses will move down to the what we call the atrioventricular bundle. This bundle is within the interventricular septum, the septum separating right and left chamber, right and left ventricle. Interventricular, the atrioventricular bundle is also called the bundle of His. That His is the name of a person. So if you choose to use it, then make the H be uppercase, as we normally do for names of people. The bundle of His divides into two, the right bundle branch and the left bundle branch. But it's this right bundle branch that was located now within the moderator band. The left bundle branch may usually divides into two as well. So you can talk of the left anterior bundle branch and the left posterior bundle branch. Eventually, from the bundle branches, we have the final component of the conduction tissue, which we call the Purkinje fibers. So this is the pathway followed by cardiac electrical impulses. That is what we call the conduction tissue of the heart. Right. So that is the anatomy of the heart in a nutshell. Our next topic will be physiology of the heart.